我的中文没有那么好，所以我用英文讲可以吗？OK，如果不懂，你跟我讲。好，谢谢。Okay, so I'm I'm Tony Wang. I'm a radiation oncologist at Columbia University in New York. I was invited by Dr. Chang and Dr. Lin to speak on contemporary managements for brain metastases, which I treat quite a bit in my institution. So these are my disclosures, and they are electronically available. So the objective of this session is to explain current treatment paradigms for the management of brain metastases, and then discuss practical strategies for different brain metastases clinical scenarios. And then to review some of the practical brain metastases cases, I'm going to show some cases and also discuss some medical decision-making strategies for a common topic I see in my practice. And in terms of my outlines, I'm going to go over some background on brain metastases, sample cases, what are the current radiosurgical whole brain radiation data, and then two particular, not yet really refined questions for brain metastases, which is the role of what do you do with multiple brain metastases, what are some of the thoughts about what do you do with large brain metastases, or even post-operative brain metastases, things that commonly reflected but maybe not necessarily discussed in phase 3 trials, for which there have been some information or data that's been published recently. So, and these are incidences I quote from US statistics, that's not global, but brain metastases is very common. There's approximately 300,000 annual incidences a year. It's more than 10 times for primary brain tumors, for which I treat a lot. About 20 to 40 adult cancer patients will develop brain metastases, and about 10% or less of pediatric cancer patients will develop this complication if they live long enough. And about 2/3 of patients develop symptoms at some point, whether it's seizures, weakness, numbness, or other neurological deficits. And a third or half patients will die simply from brain metastases progression as a part of their cancer course. So I talk about some of these older studies in the first slides because they are fairly relevant at some point, which may not make sense for it now, but these are some of the papers originally published. One of the first couple of randomized trials for the role of brain metastases. Again, these were papers that were published over about 3 decades ago, looking at the role of whole brain radiotherapy at the time when no one really understood what was the best management for these patients. So Roy Patchell published this in 1990 in New England Journal of Medicine, randomizing patients who had single brain metastases that were randomized to whole brain versus surgery followed by whole brain radiotherapy. And what they found was that in these patients that got surgery and whole brain radiotherapy, there was a median overall survival benefit versus just whole brain radiotherapy alone, suggesting that for patients that are favorable with just a single brain metastases, doing surgical resection followed by some adjuvant radiation afterwards was likely reflective of a survival benefit. Okay, and following that study, he published a second randomized trial looking at patients again with brain metastases. So single brain met. Okay, these are very selective patients who underwent surgery. All patients got surgery, but then randomized to adjuvant whole brain radiotherapy or no whole brain radiotherapy. And what they found was that the addition of whole brain radiotherapy did not improve survival, but did improve the chances of neurological death, meaning intracranial progression. So these patients may have died from other extracranial diseases, but basically that's sort of the treatment paradigm for brain metastases. And frankly, if you look at the literature, the only two really phase 3 trials that were published for this particular question in the 90s. So some more follow-up studies from the NCI cooperative group, for which RTOG NRG serves, folks started looking at the role of radiosurgery, which I know is very common here. And at this point, the question really was, well, what are considered reasonable radiosurgical doses for brain metastases? And so this is a study done by Ed Shaw at Wake Forest that looked at radiation dose escalation studies based on the diameter of your brain metastases. And they stratified it by diameter. It wasn't by volume like we used to do, that we do now quite a bit, but it's just by diameter itself. And what they found was the maximal tolerable dose, right, is dependent on size or diameter in this case. And so that's where we typically have gotten our numbers of being comfortable treating patients to, if they have a tumor less than 2 centimeters, you can go up to 24 gray. I personally do not do 24 gray routinely for my brain metastases, but if you have larger brain metastases of 2 centimeters to 3 centimeters, you might need to dose de-escalate to 18 gray and 15 gray respectively. But if you go beyond those numbers, the risk of radionecrosis starts going up to 10% or more. So those are some key things that based on these phase 3 trials, we were able to sort of extrapolate. And that kind of led to the next generation of phase 3 trials that looked at the role of just omitting radiosurgery or whole brain radiotherapy altogether. So this is the Andrews trial. This is RTOG 9805, randomizing patients who had brain metastases to, and again, this is patients that had 1 to 3 brain mets, okay? Limited brain metastasis that we learn now is about 3 brain metastases or less. And so these patients were randomized to whole brain versus plus minus SRS. And what they found was that in patients, the addition of radiosurgery did not provide really any survival benefit. However, in a post hoc analysis, if you looked at patients that had 1 single brain metastases, right? Similar to if you looked at patchel studies that had 1 single brain metastases, the survival was about a month and a half adjusted median overall survival benefit for those that had a single brain met. Okay, so what all that led was a lot of data from RTOG, because there was at least 3-4 RTOG trials that had been published at that time, and so folks actually collated that data and designed the RTOG RPA classification, which is sort of obsolete. I would say now, in terms of prognosticating brain metastases, the best prognosticator would be the diagnosis-specific graded prognostic assessment by my colleague Paul Sperduto. So the DSGPA is a way to score by specific primary site based on age, Karnofsky performance status, molecular status, extracranial disease status, and that kind of prognosticates you. So I teach my residents, it's like you're trying to apply for medical school or undergrad, you have to have a high GPA, right? It's like 4.0. If you don't get a 4.0, you're not going to get, you can't get good school. So the higher the score, the more likely your survival benefit. So I just want to share some sample cases, and the way we look at these cases have slightly changed over time. So on the far left, you have case 1, which is a patient that, regardless of age, appears to have a single brain metastases in the left frontal lobe. And then in the case 2, the middle case that I'm showing an MRI scan, you see a patient that has about 4 brain metastases on 1 axial T1 contrast scan. And on the right, I think most would agree, this patient has innumerable brain metastases just on 1 single axial T1 slice. And the way I was trained, at least back then, was typically for a patient that has case 1, I think all would agree that just doing radiosurgery for this patient was reasonable, right? Based on the phase 3 trials I just showed before, not even the more recent phase 3 trials. And then on patients on the right, on case 3, you probably would agree that you could, in terms of radiation options, this patient likely needs whole brain radiotherapy, right? This is not a radiosurgical candidate. And I'll tell you that for case number 2, at that time, based on when you were trained, at least when I was trained, the answer for this would have been whole brain, right? Because if you had more than 4 brain metastases, you weren't considered part of those 9805 trial, patchel trial. And of course, again, I don't know how practices work here, but things have started to change dramatically in terms of how we address this intermediate, I would say, between limited and extensive brain metastases by volume. So I'm going to share some of these data based on what's been published in the last couple of years. So these are randomized trials of patients who have brain metastases who had radiosurgery with or without whole brain radiotherapy. So there's about 4 trials that have been published, I would say, in the last 10 years. There's the Japanese JROSG 991 by Aoyama that randomized patients with brain metastases up to 4 brain mets who were randomized to radiosurgery with or without whole brain radiotherapy. Okay. Then there's also Eric Chang's paper from MD Anderson that also looked at the same thing. And then there's the Coker paper from Europe, and then NCCTG by my colleague Paul Brown at Mayo. And if you look at these 4 trials, basically the arms were very similar. Everybody got radiosurgery, and then they were randomized to either whole brain or not. But if you look at the actual median survival of patients that were in either of these arms, whether they got whole brain or not, the median overall survival was very similar. The exception to that rule is the MD Anderson trial from Eric Chang, which actually the patient that got radiosurgery alone had a better survival benefit. However, the study wasn't powered to look for that. So I don't truly believe that giving radiosurgery with a whole brain actually truly improves your survival. I think there's probably some statistical anomaly. I don't think even Dr. Chang was suggesting that you can just give radiosurgery alone that improves your survival. So what about the role of upfront radiosurgery? And I'm going to pause here 1 second. Am I speaking too fast? Is it okay? Do you understand? Okay, all right, sorry. So let's talk about sort of the studies that looked at patients that had multiple brain metastases who just got radiosurgery up front. So of course, you know, I'm in Taiwan, this is Asia, you know, this is a study by Japan, they're very advanced. They were already doing radiosurgery for patients with multiple brain metastases up front. And this is by Yamamoto, who they had a multi-institutional prospective observational study of patients that had up to 10 brain metastases. Okay, so typically these patients would have been whole brain back then, but no, they didn't. They upfront gamma knifed these patients with single fraction radiosurgery, and what they found was that yes. So if you look at the survival curve, the green line represents patients that had a single brain metastases, and as you can see, the patients that had one brain metastases versus patients that had 2 to up to 10 brain metastases, which is the red and the blue line, the survival was slightly different, right? So no question. But the key point about this graph isn't about the single brain metastasis. We already know that's been proven by Patchell. We also know it's been proven by Andrews, right? But the key point was the red line, which the patients that have 5 to 10 brain metastases, their survival was no different than those that had 2 to 4, suggesting, again, because this is not a randomized prospective trial, this is really a multi-center institutional study, that you can just do radiosurgery up front for patients that have more than 4 brain metastases. And that's really what the paradigm was shifted, I would say, in the late 2000s, early 2010s. So of course, once Yamamoto published that in 2015, and that was a Japanese group, right? Very excellent results. And what you can see in terms of median survival is 10 months. So then this is a Hughes paper. It was published in the Red Journal in 2019 in patients that, and this is a multi-institutional study of only US patients. So of course they had to make some differences. They increased the brain metastases to like 15 brain metastases. But the sample size was pretty impressive. This is almost nearly 2,000 patients from multiple institutions. And what they found was, again, no surprise in this survival curve, the patients that had a single brain metastases in the dark line, solid line, had a far better overall survival versus those that had more than one. But again, if you compare the survivals between those that had 2 to 4 versus those patients that had 5 to 15 brain metastases, the survival curve actually wasn't statistically significant. Though I would say the numbers for patients that had 5 to 15 was slightly less than those that had 2 to 4. But again, back then in terms of practice, I don't think most institutions weren't routinely upfront SRSing patients that had 10 brain metastases. So this is probably more for institutions that were very comfortable doing that kind of multiple extensive brain metastases radiosurgery upfront treatments. So what about, what are the ongoing trials, right? Because all the trials I just showed you before, phase 3 trials, were patients that had brain metastases with 4 brain mets or less, right? Well, what about phase 3 trials for patients that had more than 4 or 4 or more brain metastases? That would be considered, extensive brain metastases, right? Based on the phase 3 trials I mentioned. Well, there's 5 trials at the minimum. There's actually 2 more upcoming. And so they haven't closed, or they're either ongoing or closed or have not been published yet. So all these are basically asking that specific question I just showed before, but in a randomized trial setting for patients that have more than 5 or more brain metastases, basically randomizing radiosurgery or whole brain radiotherapy, one of which is hippocampal avoidance whole brain. So more to come on that. I presume the CCTG trial is probably more likely going to be published sooner. And then one was very specific non-melanoma patients that had radiosurgery or whole brain. Because I think at MD Anderson, they don't routinely whole brain melanoma patients anymore since the Australian trial. So it's really hard not to talk about brain metastasis radiotherapy without talking about hippocampal avoidance radiation therapy. So this is one of the first papers published by my colleague Vinay Gandhi, who first showed the ability to spare the hippocampus when you do radiation therapy to the whole brain. And so at that time, I think technically it was very challenging. I mean, to do that, you really need an IMRT plan. You need to have good dosimetry to actually be comfortable doing that, where you have to have good MRI scans. You have to have the contours done soon. You need to start the radiation therapy as soon as possible. So they came up with a hippocampal constraint. And this constraint has not changed, frankly, for the most part, even after NRG-CC001, which I'll show in a couple slides. But basically, you want to keep your D 100% to less than 9 gray or less, and you want to keep your Dmax to the hippocampus to 16 gray or less in general. And you should be able to achieve that with IMRT or VMAD. So NRG-CC001, as many of you know, was published in JCO in 2020. So this is a phase 3 trial randomizing patients to whole brain radiation therapy with or without hippocampal avoidance. All patients receive memantine for approximately 6 months. The first month is titration. Do you do memantine here? I don't know if there's memantine. Okay, there is. Okay. Insurance pays for that? No. Okay. All right. Okay. So, but memantine basically is, we give that routinely for up to 6 months. So, again, no surprise, the patients who received hippocampal avoidance whole brain radiotherapy was found to have less cognitive function failure at 6 months. So at 6 months, there was approximately 59.5% that had evidence of cognitive function failure versus nearly 70% of patients who had standard whole brain radiotherapy, 2 fields, parallel opposed. And this hazard ratio is 0.76 with a P of 0.03. But what's more interesting is enough, if you look at the curve carefully, is that the separation of the curves in terms of cognitive failure happens even as early as 3 months, right? We're all told to understand that neurocognitive functional decline sometimes happens as a part of a later stage of radiation therapy. But if this random phase 3 trial tells you is that at the start of it, your patients can suffer in terms of their quality of life neurocognitively if you don't do this right up front. And that can impact their quality of life permanently. So it is important to consider these patients, I think, for hippocampal avoidance. There's now phase 3 data suggesting what's considered optimal treatment for these patients. Okay, I'm going to move on to a separate topic from my outline, which is for large brain metastases. This is also a very common clinical conundrum that I deal with on a daily basis in terms of what's the right approach. I'm going to talk about a couple studies, 2 phase 3 trials at the minimum, and then there's a phase 2 as well, looking at large brain metastases. So these are patients that are a lot more difficult. Generally, if a patient has a large brain metastases with mass effect or symptomatic, I favor resection, right? I don't think radiosurgery, I think most would agree that radiosurgery is not going to improve their symptoms for a large brain metastasis that's intact. However, after a resection or even a gross total resection of even a single brain metastases, the local recurrence, if there's no adjuvant therapy, is approximately 50%. And I can show that to you based on a phase 3 trial that was published a couple of years ago. Now, I showed the Patchell papers in the first couple slides of the trial, so of my talk. So we know that giving postoperative whole brain radiotherapy, and that's the Patchell 2 paper, reduces recurrence to the surgical bed by about 50%. But whole brain radiotherapy has not been associated to improve survival. It does improve neurocognitive cause of death, but it doesn't improve survival, okay? And there are now 2 phase 3 trials that are published that suggest single fraction radiosurgery to the surgical bed adjuvantly, not salvage, adjuvant. So, soon after surgical resection improves 2 things. One, it has been shown to improve surgical bed control versus just observation, right? So there's this surgical bed cavity control. Second thing, it also has better neurocognitive preservation and no difference in overall survival versus whole brain radiotherapy. So I just want to show you, this is a representative slide of a case I just did recently. This is a young woman who presented with, imbalance and lightheadedness and dizziness, who presented with a right, occipital brain met, and kind of difficult because you can see here the borders aren't very well defined. So because of the size and symptoms of her tumors, she actually underwent a gross total resection. On the right is your preoperative MRI scan on T1 contrast. On the left is the postoperative MRI scan after surgical resection. So the question is, what do you do next, right? I imagine you see this quite often in your practice pretty routinely, right? Patient with brain, and what do you do after that? So the first paper I want to show is a paper by my colleague Anita Mahajan at Mayo, who did this at MD Anderson. But this is a phase 3 post-op radiosurgery versus doing nothing after gross total resection, right? Because oftentimes in my tumor boards, my neurosurgeon will say, oh, I'm not being recorded. My neurosurgeon will say, I got it all out, it's good, right? And you're like, okay, and then you have to negotiate. But thankfully, I don't have to, because there's actually a phase 2 trial that now says that even after a complete gross total resection, okay, of up to 1 to 3 brain metastases in this study, the maximal diameter resection is 4 centimeters or less. Patients were randomized to It's a 1-to-1 randomization to radiosurgery or observation. At 1 year, and this is 132 patients. It's pretty well powered. At 1 year, local control was 73% with radiosurgery boost to the cavity, adjuvantly, not salvage, versus 43%. That's crazy. It's a lot of patients. If I told the patient, I said, you got a gross total resection, I have it to nothing, yeah, in 12 months, you know, more than likely you're gonna have this tumor come back. They're probably not gonna sign up for that, okay? I can tell you for sure. If I tell them that, they're not gonna sign up. They're gonna boost that cavity right away. Now, I will say, the doses for the SRS dose for this trial by Dr. Mahajan was a little lower than I typically give. So the highest dose they gave was 16 gray based on the cavity. If the cavity was 10 centimeters or 10 cubic centimeters or less, they did 16 gray to the cavity. And if it was any larger than 10 centimeters, it went to 14 gray and 12 gray. I typically don't do that. I typically give 18 gray at the minimum, or 16 gray potentially. But we'll talk more about that. But in any case, another thing I think, if you're looking at this slide carefully, is that the results aren't great. Because even after you boost these patients, local control is 70%. You know, that means 30% of your patients are still gonna fail. And we'll talk about that. So the second study I wanna show you is the N107C trial. Again, this was published by Paul Brown in 2017. Again, these are patients who had up to 4 brain metastases that had resection, at least one of them. And then they either underwent whole brain followed by radiosurgery, or just radiosurgery to everything at once. Okay, the primary endpoint was cognitive deterioration-free survival. This is an important study for a couple of reasons. Because this is the study that basically said you don't need a whole brain after post-op brain meds, right? So basically, just let me refresh one more time. So this is a patient that has 4 brain mets who were either randomized to whole brain versus radiosurgery. That's basically it, okay? I mean, we talk about radiosurgery to unresected brain mets, but that's not the point of this study. And what they found was that the surgical bed control after radiosurgery, the patients that got whole brain at 1 year, there was an 80% surgical bed control. That's pretty good. On the other hand, for those that just got radiosurgery alone, the 1 year surgical bed control was 60%. It's fairly similar to the Anita trial, which is 73%. Okay, so the question is, are we giving enough dose? What's the right optimal dose surgical bed and these large brain tumors that we're treating? This is a paper published by Miniti from Italy, looking at patients that have large brain metastases. Large was defined by more than 2 centimeters in size, and they either underwent single fraction radiosurgery or fractionated radiation therapy. Okay, and the BEDs and the dosing is on the bottom left. So single fraction radiosurgery was 15, 16 gray or 18 gray, and then the fractionated radiosurgery was 27 and 3. And what they found was that those patients that had fractionated to 27 and 3 for intact brain metastases, the 1 year local control rate was about 90% versus 77% with single fraction radiosurgery, suggesting that you probably will have better tumor control. But more importantly is the rate of toxicity. Because the larger your tumor, as we saw in the Ed Shaw paper in 1905, the larger your rate of radionecrosis. And what they published here in this figure is that with fractionated radiosurgery, you probably also had less risk of radionecrosis complications based on the BED. So what about the surgical bed control that I was just showing you before, right? So Anita Mahajan and Paul Brown, N107C, MD Anderson showed a 1 year, about 73% for Anita's trial and 62% for N107C. So these are single fraction radiosurgery, surgical bed control by single fraction radiosurgery or fractionated radiosurgery. And at Columbia, we looked at this ourselves. Our success rate was a 70% success rate, surgical bed with single fraction radiosurgery. But if you look at the post-op brain metastases or post-op radiosurgery, fraction radiosurgery success rates, about 80 to 90%. These are mostly retrospective, but the other two on the last are randomized trials. So this is a study by Navaria. This is N107. This is the phase 2 trial, a hypofracture radiosurgery for post-op brain mets. The dose here is a little high. They gave 30 and 10. 30 gray, in 3 fractions. Not 10 gray per fraction is what I meant. So you had a single brain metastases greater than 2 centimeters, underwent resection, and then the investigators gave 30 gray and 3 fractions delivered daily, so Monday through Wednesday or Wednesday through Friday. 100 patients. Okay, this is a single arm. Their 1-year local control rate was excellent. It was like 99% according to what they quoted. However, the radio necrosis rate was 26%. It's pretty high. We could basically, fry that spot. So this is the Alliance trial that just closed in September. This is the question that's going to answer the whether or not radiosurgery versus fractionated radiosurgery is more effective. And this is going to answer the question of whether the standard of care for post-op brain mets should be single versus fractionated radiosurgery. I also want to point to this trial, which just got activated a few months ago by Stuart Burry, North Carolina. I'm not going to harp on this topic as much, but basically the question here is there a role for preoperative radiosurgery? And why that's important is because Dr. Burry's group basically, in their retrospective series suggested that by doing neoadjuvant radiosurgery for resectable brain metastases, not only may you have a better survival control, but you may also have a control rate, but you also have less risk of leptomeningeal disease progression. So I think the next phase of brain metastases is the role of what do you do with leptomeningeal disease, because not all leptomeningeal diseases are the same. There's the nodular type, there's the patchy type, there's many more that's coming out with respect to this issue, and I think this is going to help answer that question. So this trial just got activated. It just started accruing patients, but this will help answer the question of sequencing your SRS, which will be very interesting because if you had to do this with your neurosurgeons, you got to coordinate quite a bit because we're so used to just doing after the fact. But you know what? If the GI group can do it for rectal cancers, you can do it for brain metastases. So this is a South Korean paper I want to point out, which was dose escalation strategies for large intact brain metastases. These are patients that have brain mets that are so large, 3 centimeters or more, that that underwent dose escalation using 3 fractions. So they did 24 in 3, 27 gray in 3, or 30 gray in 3. Okay? And what they found was that the 1-year local control in patients that have 24 gray in 3 fractions was 65% versus 80% with 27 in 3 or 30 gray in 3. However, the 6-month radionecrosis rates was far higher with the 30 and 10. This is very similar to that Navaria paper I just showed you, where they did 30 gray in 3 fractions for those post-op brain metastases, and the radionecrosis rates at 6 months was like 23%. This is 37%. This is from South Korea. This is really, really high. If I have almost a 40% radionecrosis rates at 6 months for my patients, the outcome is not really good. So personally, my go-to for fractionated radiosurgery has been 27 and 3 based on the evidence I'm seeing. Okay. And this is another study that's kind of ongoing. As I mentioned about the Alliance trial for single versus fractionated radiosurgery, this is going to come on soon, which is basically asking the question is, based on the Minity paper, the Navaria paper, and the South Korean paper, and all that, should we consider going back to fractionated radiosurgeries for intact brain metastases with large ones versus just single fraction radiosurgery? So we know that single fraction radiosurgery can preserve cognitive function. However, the radiotumor control seems to be worse with single fraction radiosurgery versus fractionated radiosurgery. So this is the schema. It's not activated yet, but it's likely going to happen soon, which is going to be single fraction versus the 27 and 3 for those patients, or 30 in gray and 3, based on tumor size. And the primary endpoint is going to be about local control, favoring fraction radiosurgery at 83%. And we're hoping that result will come through. But this trial will likely take another 3-4 years before it's published. So those who are familiar, Astro published its recent Astro Brain Metastasis clinical practice guidelines. So I'm going to share some of that with you. Again, this is all publicly available if you have the right journal paper. So again, the recommendations by Astro is pretty consistent. I co-authored this with Vinay, looking at patients that had, if you have, and I'm pointing out specific questions that are a little more controversial, not the ones like case 1 or case 3. But if you have intact brain metastasis between 5 to 10 brain mets with good performance status, we now conditionally recommend patients get radiosurgery. Okay, and if you have a small intact brain metastases that's less than 2 centimeters, you should do single fraction radiosurgery. 20 to 24 gray is reasonable. I sometimes do 18 gray, believe it or not, for even small 2 centimeter tumors. if I have a tumor that's in the premotor cortex or somewhere really close to a very critical structure, I might actually dose de-escalate after that. For larger tumors, that's 2 to 3 centimeters, I may dose de-escalate to 18 gray, right from the Ed Shaw paper. Or I guess you could consider fraction radiosurgery, although I think 2 to 3 centimeters is probably reasonable. I don't know if you have to do 27 and 3 for that. But for tumors that are greater than 3 centimeters, I almost always multi-fractionate that to 27 and 3 is my go-to, or 30 and 5. Although your 30 and 5 BED is just not going to be as great, and I suspect that the control rate is poor. Because if you look at the spine data or some of the other literature out there for 6x5 versus like your 2 or 3 frac like really hypofrac doses, I think control rate really suffers if you do 6x5. And then for really large tumors, forget about it. I'd operate first and do post-op SRS. Right now, single fraction radiosurgery I think is fine. However, it's really large, I probably would favor fractionated radiosurgery based on the data I showed. These are some of the guidelines for single fraction post-op cavities. Again, this is the same, it's funny because this is the exact same dose that we use for the Alliance trial, okay? But basically, if you have a tumor cavity that's 4.2 cubic centimeters or less, we do 20 gray. I do 20 gray. And anything larger than that would dose de-escalate. If I have something that's so large to the point that I have to drop to 15 gray, I would fractionate radiosurgery that to 9 gray times 3. That's been my strategy. Again, all we could comment on in this paper was what we do for single fraction radiosurgery. What we don't know, at least pending the Alliance A071801 trial, is to justify fraction radiosurgery in a phase 3 trial, and that's hopefully going to be published by the end of the year next year. This is a busy table, but again, this is an algorithm of management from the same Astro brain metastasis guidelines. I didn't show all the figures, but I like to talk only about controversial stuff. So this is for extensive brain metastases defined by more than 5 brain mets. You stratify first by performance status, then you look at whether or not, if the patient has a good performance status, you ask about whether or not they have a large brain met or not brain met. And then you ask how many brain mets they have, and then that kind of breaks it down to either radiosurgery or potentially hippocampal avoidance whole brain radiotherapy. I will tell you that I'm probably a bigger SRS user than I am hippocampal avoidance in general. Other things that people are doing, so this is a slide shared by my colleague Arjun Sehgal at Princess Margaret. He does a lot of spine stuff, but he does brain metastases studies once in a while. So he's been doing this in patients that have like large, critically located brain metastases. Like in this case, he shared with me, is a brain mets that's lodged in the brainstem. I don't know about you, but yes, there's papers that do single fraction radiosurgery for brain metastases, and you have to drop dose. So what he does is he does stage radiosurgery almost like an AVM for larger AVM. So he did the 8 gray times 1, had them come back in 2 weeks, re-MRI'd, the tumor responded, and he did another 8 gray times 1, and shrunk his margins a little bit to accommodate from the dose. And he waited another 2 weeks to give another 8 gray. He did another 2 weeks, and then did 4 gray, and that's basically it. And what he's showing was that the tumor actually had responded to the stage radiosurgery procedure. So I'm really curious with that. There's no trials, there won't be, but it's quite. It just think outside the box. It's really fascinating, like to do the best kind of care you can for patients. So I hope I was able to show you like sort of your thought process really is how you approach different cases by their brain metastases, not just by number, but a lot of other factors as well by performance status and extra disease status as well. So I'm going to finalize my last part of my talk to just hopefully summarize what I presented was, the treatment of multiple as well as large brain mets is evolving, both by dose fractionation, single versus fraction radiosurgery, BEDs, and there are currently a lot of ongoing trials that are looking specifically for the question of extensive brain mets. For extensive brain mets, you have to take into account performance status, the size, resectability, number of brain mets, chronic disease status. For large brain mets, I resect if I can. My neurosurgeons are usually very aggressive, they'll take it out. And then for post-op brain mets, I hope I was able to show you or prove to you that almost all those cases, even as gross total resection, post-op SRS has been shown to have local recurrence that favors SRS versus observation. And this is proven in at least 2 phase 3 trials. And if after resection, I would favor SRS as a less toxic alternative to whole brain. I would not whole brain up front, if at least based on, again, the N107C trial. And then, so single fraction radiosurgery, the post-op bed has a 1-year local control rate of about 60 to 80%, which isn't great. Well, hopefully fraction radiosurgery will have a better outcomes based on the Alliance trial. And I'll pause here because I think my time is, time's up? 5 minutes? Okay, great, because I think I have a questions, questions to go over. So that's the end of my talk, and thank you very much for your attention. I don't know if we should do the questions. So, okay, so a couple questions I got is, would you include surgical tract in post-op radiosurgery? Yeah, so, you know, it's so funny because I use the gamma knife, right? And I don't know about here, but over there, but the gamma knife, at least in stateside, I have to do with a neurosurgeon. And this question comes up all the time. And what's helpful is my neurosurgeon's been in there and then kind of getting me a sense of how mucky that surgery was, if they felt that it has any cross-contamination. I typically do cover it if it's like a very deep brain metastases. I do worry about that, and I don't, unless that tract from the surgical approach to the brain is in a really critical area, I generally try to cover it if I can. Okay, the Alliance trial that I've referenced in my paper that just closed, it actually has specific dosing guidelines about how you contour your post-op cavities. It's very specific, and if it is a positive trial, that will likely be the next standard of care for post-op brain metastasis. It's going to be very fascinating. I mean, this is breakthrough stuff in terms of how we approach brain metastasis, improve survival, improve local control in particular. How would you evaluate SRS dose with a linear accelerator? Well, so the dosing, the Astro guideline I just showed before was applicable to all platforms. So the 20, 18, 16, 24 gray, it was by diameter. And you know, I would argue because with Linux, your isodoses are higher, so it's less of a hotspot. And some argue that maybe that's less of an issue for radionecrosis rates. You know, we do have specific, you know, things with gradient index and homogeneity index that we use, and also conformality index. If it's specific linear accelerators, I guess it likely be slightly different in terms of because the maximum dose is going to be different. So we really depend on the situation. It's like for very small brain metastases, your gradient index is going to be compromised. And for very large tumors, obviously you want to have a better homogeneity index, conformality index for those kind of patients. I think those are the questions I have so far on the track, unless there's any more. And then I think I have questions on the interactive thing. I don't know if it works. Okay, so do I just go over the questions and have answer? Is that okay? So again, I was asked to provide some questions at the end of the talk. So I guess I'll say the first question is, what difference does hippocampal avoidance whole brain radiotherapy plus memantine have compared to conventional whole brain radiotherapy plus memantine? And I guess, do you just answer this, or how does that work? Do I say anything? Oh yeah, you need to scan the QR code to answer the questions. The audience does that, right? Yeah. Okay. And I guess, do I go over that or just okay? Okay, great. So 100%, yeah, the answer is D. Okay, we can move on to the second question. Uh, yeah, oh, great, okay, so what is the rate of cavity recurrence at 12 months in patients not receiving postoperative radiosurgery after brain metastasis resection? So. Okay, so a little more mixed, but generally it's that C is probably more on the correct side, and then D is a little higher. But yeah, if you looked at the Anita Mahajan paper, about 41% had local control at 12 months. So the answer would be C because that's 60% really failure rate. Unfortunately, at 12 months after radiosurgery. So so at least that's just based on that phase 3 trial. Okay, we can move on to the last question for this session. What is eligible for hippocampal avoidance whole brain radiotherapy in patients with multiple brain metastases? Okay, yes, so the NRG-CC001 required tumors that had to be more than 5 millimeters away from the hippocampi for eligibility. Patients couldn't have leptomeningeal disease. You couldn't have significant hydrocephalus because that likely alter your brain anatomy and you may not actually cover the hippocampus if there's distortions of the brain. And then patients couldn't have a VP shunt as well because again, it's all based on the geographical distortion of any sort of foreign object you put in the brain. Also, small cell, it wasn't allowed in the CC01 trial. Germ cells and lymphomas generally aren't allowed that as well, just in terms of eligibility for hippocampal avoidance. So that was the last question. Is there any other questions from the audience of our talk? Yes, sir.
The ongoing study of SRS with or without whole brain radiotherapy, it sure include patient of the brain metastasis as many as 30 brain metastases. So I'm just curious about how to conduct the SRS for patient with 30 brain metastasis. One lesion, 1 day, or total 30?
Yeah, for that trial there's these 5 trials I am aware of that are doing that SRS for extensive brain metastases. And my understanding is that generally it should be done in one fraction or 1 day. However, for that one, I don't know if you can stage it, like have them come back another day to finish the rest of it. That's a possibility. For LINAC-based, it's not much of an issue. For like Gamma Knife, it does become an issue if you're going to have to treat for a long time. So I don't have that protocols with me. It's just, but I understand it all has to be single frac essentially. Does that mean you can space it out in 2 days? That's a possibility, but I don't know. Yeah, that's a good question. I'm not sure if it's in the I mean, I've treated up to 30 before. Yeah. I don't like doing that, or I may have to come back another day. I think that should be eligible. I don't know for that trial if that's eligible to do that or not, though. It's a good question. Yeah.
May I have a second question?
Yes, please.
Sometimes we are asked to spare brain radiotherapy for single small brain metastasis in lung cancer patient who will plan to have small molecular target therapy.
Yes.
How do you think about that?
I deal with that at my tumor board all the time. I'm sure a lot of you are doing that for many years. So I think for patients that have a single brain met that are not likely going to be, progression is not going to be a matter of life and death, and they're getting followed with MRI scans every 6 or 8 weeks, I'm okay with that. I mean, what I will say is that you have a therapy of radiosurgery that has a 90% success rate of controlling with radiosurgery, and unless the molecular, drug has been shown to have control rates similar to that, you're basically offering patients suboptimal treatment for this patient, right? But I understand it's a common issue. So as long as these patients are being followed very closely with MRI scans, and then at the first sign of progression, continued progression, I would offer SRS for those. So I think that needs to be a very clear discussion with the patient, because the patient should know they had the option to alternatively choose what's considered standard therapy. Radiosurgery for intact brain metastases, small ones at least, like you said, has control rate of over 90%. You have to find some, I mean, think about an IRB study, right? If you say, I'm going to give something 90% control rate, I'm going to give something else that has like 70% control rate systemically, how's that going to go through IRB? It wouldn't. And so it's almost like, you have to offer someone that, at least based on the evidence, has good control rates. But again, you can argue for small brain mets that's not going to cause symptoms if it's growing slowly, ever so slightly. If they want to defer that, I'm okay with that. I'm not against it. Yeah, good question. Oh, sorry, okay. All right, well, thanks again for your attention.